So as you'll have seen already, Faye has handed out a copy of our book. We chose the Physicians for Life conference to launch our book on how to discuss assisted suicide because the reason Blaise and I partnered on a project to develop apologetics that would help people have very difficult conversations about a very relevant issue is because we realized after the Carter case that the arguments we had been previously using to condemn euthanasia and assisted suicide were no longer effective. Because for most people, prior to the legalization of euthanasia and assisted suicide in Canada, we were relying on policy arguments. We were saying that this was bad policy because of the slippery slope that euthanasia regimes always end up in. And I'll be covering that in further detail at the end of this presentation, but you already heard quite a few examples from Dr. Will earlier this morning. And so the slippery slope argument, which isn't so much a fallacy, if we look at the Netherlands, if we look at Belgium, if we even look at Switzerland, it's a demonstrable fact. But now, with the Carter case stipulating that euthanasia is legal in Canada, the response of people to genuine concerns by activists such as ourselves saying, well, this actually exploits vulnerable people, it places them in danger. The response to that by groups like Dying with Dignity was, well, safeguards. We'll put safeguards in place. We'll put safeguards in place to ensure that all of the scenarios that you are highlighting will not actually take place. And that put us in kind of a conundrum. When I wrote a book about a year and a half ago that was published last year on the culture war in general, I had a chapter on eugenics and euthanasia where I traced the historical and cultural context for euthanasia. And again, Dr. Will went over some of that this morning. And it was actually Blaise, when I was giving presentations on the historical context for euthanasia, who would keep on asking me, so why is it wrong? Why is it wrong? And you can't use religious arguments, because many people aren't going to agree with you. You can't use arguments that say, appeal to the dignity and the inherent character of the medical field, because that's now up for debate. You're going to have to give me a secular argument for why suicide specifically is wrong, that somebody who doesn't hold the same worldview as you will actually be able to accept, and in fact will actually change their mind upon hearing. And at the time I said, look, I think the only good argument we have right now is the public policy argument, because we can illustrate by looking at other countries what happens when assisted suicide and euthanasia is legalized. But I started doing a lot of brainstorming because I realized that that wasn't enough. And then I started doing some research into what the views of Canadians on this issue were. And it's really stunning set of statistics. About a decade ago, they did some polling of what Canadians felt about the issue, and over 70% of Canadians already supported euthanasia and assisted suicide, 70%. But that number dropped by nearly 30% after a 15-minute conversation. Now, that simply meant that rather than just lobbying and rather than simply researching the slippery slope effects of the public policy, we were going to have a lot of 15-minute conversations if we were going to persuade people. But the good news was that people were actually willing to have a discussion about assisted suicide and were willing to change their perspective if they were presented with compelling talking points. And as Faye mentioned in our biographies, both Blaise and I work for a pro-life organization that specializes in conversational dialogue, especially street dialogue. So we spend a lot of time talking about abortion with people and persuading pro-choice people to be pro-life. I personally have seen hundreds upon hundreds of people radically change their minds over the course of a compelling conversation with good apologetics. And the way we start those conversations is by finding out where the common ground exists. And it seems like there's not a lot of common ground between the crowd over at Dying with Dignity and ourselves. But when you start to look at what the general population that has more or less come over to the assisted suicide position because all of the terms used to advocate for it already resonate with them. Right? Dying with Dignity, one of their slogans for a time actually was, your life, your choice. We've heard this terminology before. They appealed to autonomy, they appealed to freedom, and so the arguments that the euthanasia and suicide activists were utilizing were very familiar, and they weren't being presented with a compelling counterpoint. And one of the things that we realized very early on is that if you use the term assisted suicide, if you frame the conversation around suicide, suddenly people are more willing to listen. And again, Dr. Will mentioned that this morning, but we realized that if you look at the terminology that these activists want to use, right, euthanasia, which is Greek for good death, but increasingly it's physician assistance in dying, they're moving further and further away in their terminology from the phrase assisted suicide, and that's because almost everybody knows somebody who has suffered from mental illness and gone through some dark times. Almost everybody knows somebody who has had suicidal feelings at some point or another. Almost everybody knows somebody who has actually tried to commit suicide, and some of us unfortunately know those who have succeeded. So the word suicide still holds an immense power because people instinctively recoil to that word. It has a very negative connotation, which is why it's so important that we use the term suicide, and we essentially frame the discussion around a term that people are familiar with and which automatically makes them more willing to listen to us in the first place. The second thing that we need to bring up in order to establish common ground is the concept of equality. And again, this morning, Dr. Will discussed how euthanasia advocates or suicide activists are using concepts like equality in order to claim that eventually everybody will have the right to commit suicide. That suicide on demand is an inevitability once you declare the right to die to be an inalienable right. And so when we start talking about equality in the other direction, that's when we can start to make a lot of headway. And before I let Blaise detail that, I want to just explain how I came to that realization, because as I was grappling with how to establish common ground with somebody who didn't have the same worldview as me, and somebody who was supportive of assisted suicide, I was thinking, okay, the number one thing they're going to bring up to me over and over and over again is choice. They're going to say it's the person's choice. Who are you to tell somebody who's suffering greatly that they can't kill themselves, that they can't end their own lives? That is not a compassionate position to take. And inevitably, you're going to look like somebody who lacks compassion and look like somebody who wants to sentence somebody to horrible weeks, months, or even years of suffering because of religious beliefs that they don't hold as well. And I was thinking, I had heard a Dying with Dignity debate with Alex Schadenberg of the Euthanasia Prevention Coalition. And in the space of 1 hour, the Dying with Dignity advocate actually went from saying, we just want euthanasia to be legal for people with terminal illness. In the space of 1 hour, he admitted that he thought it should be available for people with mental illness and depression as well. And the day that the Canadian Parliament passed their euthanasia bill, there were 3 people on a panel on the CBC. I was listening to it in my car, complaining about the bill. When I first turned the radio on, I'm like, they're complaining about it. That's good news. I'm probably going to agree with them. Turns out they were complaining because people who have depression couldn't access the same service. And that one strikes pretty close to home for me because a lot of members of my family and a lot of my very close friends either have or still do struggle with chronic depression. So I was trying to imagine the country that suicide activists want us to live in. And they're saying this is about choice and equality. Well, let's say that myself, I do not struggle with chronic depression. Let's say I walked into a hospital and I said, you know what, I'm here to request assisted suicide. And they reviewed my records and they said, well, he has no history of taking antidepressants. He has no history of needing psychiatric care. I'm sorry, sir, you're far too healthy and you do not qualify for this service. And then right behind me, one of my friends or family members comes in and says, excuse me, I'd like to request assisted suicide. And they reviewed his or her records and realized they've needed counseling, psychiatric care, they have a history of taking antidepressants, and they would say, right this way, sir, the doctor will kill you now. In what universe am I and this family member of mine equal under the law? The law views my life as so valuable that when I'm requesting this service, I am turned down because they have already made the judgment call. They have already made the choice for me. And when my family member comes in right behind me and requests the same service, the reason he is permitted to access that service is because the government, again, has already made that choice for him. We're not equal because the government has inherently judged my life as worthy of living, worthy of suicide prevention, and has judged my family member's life as so worthless that their request for a suicide will not result in suicide prevention, but will result in suicide assistance funded and facilitated by our government and our healthcare system. So the two fundamental premises that we hear from assisted suicide advocates, equality and choice, fall when you just paint a very simple picture about two people requesting the same service. This isn't about choice, it's about the state deciding who has lives worthy of protection and who does not. And that's something that's so important to talk about, and that's the premise of the little book that you've all received. So nobody worry about taking notes during this presentation because we're going to cover a lot of material, but we got you all a copy of the book because the number one thing Blaise and I were hearing as we had discussions about assisted suicide is that many people weren't having these discussions, weren't engaging with their peers because they didn't feel equipped to have easy conversations and to articulate their position without falling back on their faith or without falling back on the slippery slopes of Belgium and the Netherlands. So this book is for you to take with you, and in the rest of this presentation, we'll be articulating even further how to have these discussions.
I think I got this. All right, so fundamentally, this is a suicide issue. This is where we have this cognitive dissonance around this issue, right? On the abortion debate, when you have a wanted child, it's a baby. When you have an unwanted child, it's a clump of cells, a blob of tissue, right? That's the cognitive dissonance that we need to attack. Here, it's a question of suicide, and suicide prevention or suicide promotion, right? The key question at the heart of this debate is who gets suicide assistance? And who gets suicide prevention? We often start conversations, we've been street testing a lot of these arguments at the University of Toronto and at Ryerson University downtown. We'll often start by asking people, what do you think about assisted suicide? Oh, well, I think it should be legal in these sorts of situations. Do you think there should be any restrictions? Oh, yes, maybe. Okay, what do you think about suicide? And immediately you see a change on people's face. Well, I think mental health is really important. Mental health awareness is important. Okay, well, how do you decide who gets suicide assistance and who gets suicide prevention? And you've set up the dilemma. We're attacking that cognitive dissonance. Now, there are three ways that we can answer this question. First is what we're calling the split position, which is that we assist some suicides, we prevent others. There's a total choice position, which is that we could assist anyone, or there's the pro-life position, which is that we would prevent anyone's suicide. So I'm going to walk through these positions very briefly to give you a sense of the kind of arguments that we found useful in conversation, building on that common ground of suicide prevention and of human equality and human rights in order to change minds. I'm going to skim through the details, but you've got a lot more practical tools in the book. First, though, I'm going to start by taking a step back and looking at the story of Viktor Frankl and the life of Viktor Frankl, right? He was an Austrian neurologist and psychiatrist, as well as a Holocaust survivor. In the 20s and 30s, he concentrated on topics of depression and suicide then and developed effective suicide prevention strategies. He found that normally people have a collection of meanings that lead sense and purpose to their lives, right? So things like health or approval of one's peers, material wealth, finding love, family, comfort, happiness, etc. Yet he spent World War II going through several concentration camps. He's a survivor of the Holocaust. And in a Nazi concentration camp, none of these usual meanings were present. In Frankl's experience, many people simply gave up on life under these conditions, and they chose suicide in one form or another. But other people didn't. And Frankl's question then was, what's the difference between these two groups of people? What drives some people to continue fighting while other people will simply give in? And his answer is that the survivors had some meaning or purpose, some hope to propel them forward. He came up with a formula, D equals S minus M. Despair is suffering without meaning. So there was extraordinary suffering in a Nazi concentration camp. But it wasn't suffering that determined despair. Despair is suffering without meaning. So Frankl saw that life could have meaning under all conditions, even in the extreme suffering of a Nazi concentration camp. I introduced D equals S minus M here because Viktor Frankl's insights are often helpful in conversation when you need to shift from the head to the heart. Sometimes logic alone can only get us so far. In conversation, I've found that his experience and his conviction can touch the heart and reach a person at the level of intuition. It can inspire people. It can inspire them to see, to change their perspective and see the situation in a different way. So as we go through these three positions, I'm going to point out this pattern of D equals S minus M that we can see all the way throughout. But first, the split position. So how do we decide who gets suicide assistance and who gets suicide prevention if both are on the table? This is the view that most people have. Most people hold the split position in our society. We need to understand that suicidal despair is always a symptom of some other unmet need. That desire to die is changeable. Suicide prevention is a human right. Suicide assistance is a human rights violation. And our moral duty to the suicidal is to prevent self-harm, never to facilitate it. The split position splits human beings into two classes, those whose lives we value and those who we think are better off dead. And our job is to put them back together, to put those two classes of human beings back together. One of the techniques that we find useful to see what kind of position someone holds is what I like to call trot out the teenager. So if you're familiar with anti-abortion apologetics, it's quite similar to trot out the toddler. So if somebody is saying something like, you know, you have a right to die, it's your life, it's your choice, when somebody brings up an argument of autonomy or freedom, I would trot out the teenager and ask, well, what about a 19-year-old who is suicidal because of a breakup or a failed exam? Right? And we can see if someone holds a split position. This is a classic case where most people would go for suicide prevention. So we can test to see if they hold the split position or the total choice. We'll get to total choice in a second. But assuming they hold the split position, we've established that they agree with suicide prevention, at least for some people. So this whole slogan, this whole autonomy argument, my life, my choice, for the split position, it's only true for some people, right? If it was really about choice and autonomy, then you would hold the total choice position. Then suicide prevention would always be an infringement on that autonomy and that self-determination. So if we only believe in this for some, it's not about freedom, it's about a judgment. There's a judgment that some lives are not worth living, which was here. Sorry, one second. A judgment that some lives are not worth living and some people are better off dead. When we hold the split position and suicide assistance is only for some and suicide prevention is for others, there's always this underlying judgment that splits people into two classes. This is where we get this human rights violation, that we treat human beings unequally. If we believe in human equality, why would we prevent some people from harming themselves and assist other people? We have to remember that being suicidal is always a symptom of some other unmet need. So anyone who works in suicide prevention will tell you people who verbally propose suicide often do so as a cry for help. They often inform people of their plans to provide those people an opportunity to talk them out of it. The legalization of assisted suicide, though, has led many people to treat this verbalizing plans for suicide as a request rather than a cry for help. Isn't it true that people often propose suicide in order to be talked out of it? Isn't it true that being suicidal is often a cry for help, a symptom of despair over some other unmet need, that D equals S minus M, right? We need to treat the illness and not the symptoms. So we ask, why do we quit on some people? Why do some people get suicide assistance instead of suicide prevention? We find that QUIT is a helpful acronym for classifying many of the reasons that people will give for justifying assisted suicide. We'll take it in reverse order because it usually starts with the most restrictive terminal illness, or it could be an incurable condition, or unbearable suffering, or quality of life concerns. So there are a lot more strategies for how to respond to each of these in the book, but I'm going to go through some of the main points quickly here. One of the tools is to test the limit. So once we start challenging, once you push and test the results, test the lines that people draw, we'll find that it's often an arbitrary line, often fuzzy lines, right? When someone's standing on the ledge, who do we push and who do we pull? These are opposite responses. Suicide prevention and suicide assistance are opposite approaches. So we better have a pretty good reason why we should go in one direction or the other. So for example, with terminal illness, how close to death does someone need to be? Days, weeks, months, years? If you say 3 to 6 months, but someone else says 5 years, why should society accept your line as opposed to someone else's? How do we decide? Isn't that arbitrary? Or with an incurable condition, we see fuzzy lines and rapidly expanding lists. Quadriplegia, paraplegia, an amputee, Down syndrome, autism, type 1 diabetes, blindness, deafness. What kind of conditions, what kind of incurable conditions might qualify someone? Or what constitutes unbearable suffering? How much suffering does one need to endure until we assist rather than prevent the ultimate self-harm of suicide? How do we measure that suffering? Does the suffering need to be physical to qualify for suicide assistance, or does psychological suffering count? When we start asking these questions, people are all of a sudden a lot less certain of their initial position. Or also, it's important to assess for ableism and assess for ageism. We'll get to ableism a little later, but for example, quality of life, to assess for ageism. When we have situations of people availing themselves of euthanasia because they're tired of life, right? Is that a reason that we would accept for a 90-year-old, a 40-year-old, a 19-year-old? Right? I was talking to a student at the University of Toronto, and he said, well, I think that if somebody's, 80 years old and they have early onset Alzheimer's and they're quadriplegic and they're facing all these other issues, I think they should have the option of assisted suicide. And I put that question right back to him and I said, okay, what if somebody is that same age, facing those same conditions, but they're not quadriplegic? He says, well, I mean, we should also offer mental health resources to people and help them find the root of their problem. And you can see this inherent ableism that we need to point out to people, right? Or the ageism. I was talking to another student at the University of Toronto when I trotted out the teenager to check the belief on suicide assistance or suicide prevention. I said, okay, well, what if a 19-year-old was in that same situation and felt that they were tired of life? And the student responded and said, well, I mean, your teenage years are a turbulent time of life. You should be able to help people through that. And I said, well, don't you think that old age could be a turbulent time of life as well? Why wouldn't we respond with that same duty to prevent self-harm, that same suicide prevention, that same mental health response to someone who is older? And he said, I never thought about it that way. Right? We can change people's perspectives by asking these questions. So let me go through a few other strategies under QUIT. With the terminal prognosis, we have the issue of uncertain prognosis, right? So take the case of John Norden. He was diagnosed with ALS at age 18. He was told he would get progressively worse. He would die within 3 to 5 years. And as an athlete and someone who worked in construction, took pride in his physical strength, and he worked with his hands, that diagnosis was devastating. He said if he had been offered suicide assistance, that he would have taken it. He became depressed when he soon had twitching in both hands and lost his ability to grip. But 6 years after that initial diagnosis, the disease progression stopped. In 2012, at age 75, he explained how his condition is basically the same. He still can't grip and he needs help, but he's married, he has grandchildren, he has a degree in psychology. He has found that meaning and value in his life because he was not offered suicide assistance when depressed, and he was speaking out in Canada and the United States against assisted suicide. So there's that uncertain prognosis, that uncertain future. But I think the most powerful piece of data that we can put on the table about terminal prognosis is research done by Dr. Harvey Chochinov at the University of Manitoba. He holds the Canadian Research Chair in Palliative Care. And a team of researchers that he led did a study on terminally ill cancer patients and the will to live, the desire to die. And they had these patients entering hospice care in their last days, weeks, at most months of life, rate themselves on a variety of factors, including their will to live throughout the day, throughout their final days. They found that over a 12-hour period, the patient's will to live could fluctuate by 30% or more. And over a 30-day period, a patient's will to live could fluctuate by 60 or 70%. There were extreme changes within some individuals, even over the shortest time period examined, this study in The Lancet reported. And these large fluctuations suggest that the desire to die is highly unstable among the terminally ill. Right? So we can see that it was things like a visit from a family member or a friend, or a counselor or a chaplain, or better pain management. Right? In the first few weeks of entering hospice care, a decrease in the will to live was most strongly correlated with anxiety, feelings of anxiety or depression. When I bring this up in conversation to people, I explain a few of the numbers, a few of the studies. I might ask somebody, take two cancer patients, the same stage of their disease, the same pain, the same symptoms, the same situation. One's suicidal, one's not. What do you think the difference is? What do you think would lead one person to be suicidal and one person not to be? We can see here that D equals S minus M again. What is true of the concentration camp prisoner is also true of the cancer patient. We might be dealing with cases of extreme suffering or with limited time left, but we can see that the difference between hope and despair is not determined solely by suffering, but by other factors, whether or not somebody can find that meaning or purpose in life, or whether or not we can address those unmet needs. Being suicidal is still a symptom of unmet needs, even for the terminally ill cancer patient. Now, with incurable conditions, often we need to assess for ableism, because somebody might start with terminal illness, but I often ask, what about somebody with a disability? Should they qualify as well? And the split position is inherently discriminatory. At its core is often this lethal ableism, right? So when the movie Me Before You was released, the film tenderly highlights the decision of a disabled man to kill himself to free his girlfriend from the burden of living a life with someone as damaged as himself. At the time, international disability rights advocate Liz Carr, an actor and activist, offered a stinging rebuke. She said, when non-disabled people talk about suicide, they're discouraged and offered prevention. Whereas when a disabled person talks about it, though, suddenly the conversation is overtaken with words like choice and autonomy, and people are rushing to uphold these prized principles, whilst talk of prevention and mental health support are rare. Right? People often think that they're being more accommodating to those with disabilities by offering them access to the service. But in conversation, when we can ask them a question, and we can use this tactic that I will call, what about the wheelchair? Bring up two people in identical situations. One has a disability, one doesn't. The split position proponent's instinct is to support assisted suicide for the person with the disability, and they think it's compassionate. Once we flip that back on them and say, you see what you just did there? You just said if somebody's, the only difference, and somebody's is in a wheelchair or they have this disability, then you would offer suicide assistance instead of suicide prevention. Don't you think that's ableist? Don't you think everyone should have an equal right to suicide prevention, even if they have a disability? Once we can phrase this back to someone and reframe it, people are often a lot less comfortable with that ableism, but we just need to point it out. We need to ask them questions, we need to get it on the table, we need to point it out. Let me go through a few other quick scenarios. There are lots more dialogue techniques in the book, but when we get to unbearable suffering, and we're looking at cases of physical pain, Dr. Harvey Chochinov, so again, who holds the Canadian Research Chair in Palliative Care, he wrote in the Toronto Star a few years ago that at their time of licensure, physicians generally have been taught less about pain management than those graduating from veterinary medicine. And that 70 to 80% of Canadians, for 70 to 80% of Canadians, palliative care is simply not available. The vast majority of pain can be managed. It's an access and education question. But what about those cases where it can't be managed? There are some cases where we don't yet have the medical knowledge to completely manage physical pain. For example, take the genetic condition of epidermolysis bullosa, or EB. It's a rare condition that causes skin fragility and a never-ending series of blisters across the whole body. Young patients are often called butterfly children because the skin is said to be as fragile as a butterfly's wings. As the skin blisters and falls off, open wounds are left behind. And EB involves regular physical pain. Its bandages across the body must be changed daily, a process that takes hours. Life expectancy is often greatly reduced. For someone with EB, suffering is unavoidable. But D equals S minus M. Despair is not. Jonathon Petra, for example, is a teenager living with EB in Ottawa, Ontario. While he describes EB as a cruel thing and deals with unavoidable pain on a daily basis, Jonathon's suffering does not give way to despair. When asked how he gets the strength to get up every morning, knowing what he'll be facing, Jonathon replies, that strength comes from the people around me because they do believe in me, and I can get through it. And he found hope in attending an EB conference and meeting other children with the same condition. He said, I knew I wasn't alone anymore, he said, and he became an ambassador to start helping people with EB. Or take James Dunn, who's living with EB in the UK. As a child, he played hockey to take his mind off the condition, but as a young adult, photography distracts James from the pain. However, he can't operate a camera anymore because of the condition of his hands. So he needs assistance from another person. He needed assistance just to hold the camera, until designer Jude Poulin developed a bespoke solution for James to operate the camera using a tablet. James says, I want people to remember that this is what I enjoyed, and that this is where I found my happiness. Remember D equals S minus M. Despair is suffering without meaning. Both Jonathon and James find hope and meaning through the support of other people around them, through finding a purpose in life, just like anyone else. People often say, who would want to live that way? We can say that about the cancer patient, the concentration camp prisoner. That's the wrong question. Of course, no one would want to live that way. The real question is, what do we do when that happens? I would hope that someone would care for me more than I care for myself if I became suicidal at that time. Do we care for the person in that state, or do we kill them? I'm going to breeze through a few other key points here, but there are more details in the book. If we look through quality of life, I think the important thing to look at, we can see, for example, in suicidal regret, that only 10 to 14% of individuals who survive a suicide attempt will go on to commit suicide in the next 10 years. Suicide's a permanent solution to temporary problems. When we point out these stats to people, they highlight the belief in suicide prevention. But to bring it back to cases of assisted suicide, if we look at Oregon, with Oregon Public Health's data on the reasons why people choose assisted suicide, 92% cite losing autonomy, 89% say they're less able to engage in activities that make life enjoyable, 79% say loss of dignity, 50% losing control of bodily functions, 40% feeling like a burden on family, friends, or caregivers, 25% cite inadequate pain control or a concern about it, and 3% financial implications of treatment. The disability rights advocacy group, Not Dead Yet, they look at this and they say these are disability issues. Not being able to enjoy the things in life, losing autonomy, having less control over your body, having concerns or fear about pain, right? Why are we giving suicide assistance to people with disability issues and suicide prevention to those without? At the end of the day, we get these two classes of citizens, this human rights violation, right, where we're treating people in an unequal way. Now, some people might try to solve this problem by saying, okay, I guess we need to treat everybody equally. I guess everyone needs to have an equal right to suicide assistance. And I'll just breeze through quickly how we respond to the total choice position. Our job is to split the total choice position, to find that common ground and find that intuition to prevent at least some suicides, and to bring people back to the split position. So a student I was talking to, Chad at Ryerson, made this movie. He's like, well, I guess everybody needs suicide assistance. I just asked him, should we ever prevent suicide? I trotted out the teenager again. For some people, that's enough to split the position. Just find one case where suicide prevention is agreed upon, and then we have that, we're back to that split position. Or what is rational suicide, right? If somebody says, well, it's if they're rational, they have good reasons. Well, suicidal ideation is one of the diagnostic criteria for depression. How do we distinguish between being suicidal as mental illness, a cry for help, or a rational decision? How do we tell the difference between someone who's of sound mind and a suicidal person who needs psychological help? At a deeper level, we need to appeal to the question of what is our duty to the suicidal? Questions like, do we have a responsibility to decrease the will to die? What's our duty to our fellow human being? Is the desire to die a rational desire or an indication of a social failure at some point? We have a series of questions and some stories that you can use to reach the heart. Because at the end of the day, our appeal to the total choice absolutionist becomes an appeal not to the head, but to the heart. The story of Viktor Frankl, D equals S minus M. Or if we take the case of Peter Singer, a bioethicist from Princeton who's the embodiment of the total choice position. He advocates that human beings, that even non-voluntary euthanasia can be acceptable in some cases. But when his own mother was ill and dying, he responded in a very different way. She'd come to a point where she couldn't recognize him anymore. And by his own theory, didn't meet the definition of a person. Yet he cared for her. He spent money, he spent time, and when asked why, he said, I think this has made me see how the issues of someone with these kinds of problems are really very difficult. Perhaps it's more difficult than I thought because it's different when it's your mother. At the end of the day, very few people actually believe this total choice position. Most people believe that suicide prevention is true in at least some cases. So our job is to split that total choice position. And with a split position to show that it's inherent discrimination. It breaks people into two classes, and that suicide prevention is there for a reason, because being suicidal is always a symptom of some other unmet needs. But then for the pro-life position, we also need to make a positive case for the pro-life position to show that this is a position worth adopting. I'm going to skip through this. We know some of this has come up through the presentation. It's in the book. We just show what it's not, what it is, right? Psychological health resources, pain management, palliative care. If you want to look up dignity therapy, that's been developed by the same researchers doing the study on the transient desire to die. They've developed therapy in palliative care for people to help them find meaning and purpose in life, to deal with those social, emotional, psychological issues that people might be facing. Dr. Will Johnson says, when you only see death as a solution, you throw creativity out the window, right? So we need these kinds of creative solutions. We need this positive pro-life response to show that this position is worth adopting, as we show the others are untenable. The split position as a violation of human rights that splits people into two classes, and a total choice position that no one truly believes in. Otherwise, we'd have to throw everything we know about suicide prevention out the window. But also, one last reason we have is because the alternative is grim. For those who still think there are some narrow circumstances where it should be legalized, we can appeal to the consequences of legalization. The consequences are unpalatable because the split position and the total choice position cut like a double-edged sword. The fundamental inequality of the split position passes judgment that some people are better off dead, while the autonomy argument of the total choice position cuts down any safeguards or as restrictions on individual freedom, inevitably leaving many people increasingly vulnerable and with vanishing protections.
Rebecca just signaled 2 minutes to the Q&A, but I'm going to take 4 because we gave the book out, which answers a lot of the questions. I just wanted to briefly cover the last set of anecdotes that I think are useful in a discussion context. Well, we started this presentation off by discussing how the slippery slope argument was no longer an effective means of persuading somebody to oppose assisted suicide after the Carter case legalized euthanasia, and the response to such concerns became safeguards rather than outright opposition to assisted suicide. Now, I'm going to give you a couple of examples of what the slippery slope looks like. You heard a bunch this morning already. These examples are useful not because they make assisted suicide wrong. These examples occur because assisted suicide is wrong. And I just want to briefly take a look at some of the terminology that's used in a couple of these examples and point out how looking closely at these stories gives us the anecdotes that we can utilize to bring people over to our position. Because I don't know how many of you have had a discussion about assisted suicide before, but when I engage with people on this issue, and I have a whole bunch of very left-wing friends from university that I still keep in touch with, and they often become my guinea pigs when I work on these arguments, I'll phone them and I'll run it by them, and we'll go back and forth a bunch of times, and I'll test my arguments out on them. And one of the main things that they say when I say, well, you know what, assisted suicide will result in, euthanasia in children, for example. And they will say, no way, that would never happen. And I'd be like, well, happened in Belgium. And that story, that reality really starts to shift their understanding of the debate. But I want to read you a short little story from 2014, the Daily Mail. An elderly husband and wife have announced their plans to die in the world's first couple euthanasia, despite neither of them being terminally ill. Instead, the pair fear loneliness if the other one dies first from natural causes. Identified only by their first names, Francis, 89, and Anne, 86, have the support of their 3 adult children who say they would be unable to care for either parent if they became widowed. The children have even gone so far as to find a practitioner willing to carry out the double euthanasia on the grounds that the couple's mental anguish constituted the unbearable suffering needed to legally justify it. The couple's daughter has remarked that her parents were talking about their deaths as eagerly as if they were planning a holiday. John Paul, their son, said the double euthanasia of his parents was, and I quote, the best solution. If one of them should die, the one who would remain would be so sad and so totally dependent on us, he said. It would be impossible for us to come here every day and to take care of our father and our mother. Now, I can see by your faces that you guys are identifying a lot of the problems with this scenario already, but I want to hone in on one. Suffering, as we've seen in this presentation and presentations this morning, has a lot of different meanings. But the way I use this anecdote is I propose to people something very simple. Imagine any kind of physical pain. Each of you actually, imagine the worst physical pain you've ever experienced. Now imagine if everybody who loved you, the people that you had sacrificed for the most, the relationships you had invested in the most, imagine if you suggested that maybe suicide was a good option for you because you felt like a burden, and then they agreed with you. Most people I pose this story to immediately recognize what I'm getting at. They realize that suffering comes in different forms, but I don't think there's any level of suffering that can quite compare to your children who you loved and raised and cared for and expected to be caring for you in your old age to agree that killing you is the best solution. I'll give you one other short anecdote and then we'll shift to questions, and it's in a documentary that was released by HBO called How to Die in Oregon, shortly after assisted suicide was legalized. And they were interviewing people who had ordered the poison pills that they were going to take to kill themselves ahead of time to ask them why they had made those orders. And there was one elderly man who was sitting next to his daughter. He was still fully mobile. And the interviewer said, "So why did you order these poison pills?" And he said, "Well, when I get a bit too old, I don't know if there's anyone to take care of me, and so I've procured these pills so I won't become a burden." And then he finished the sentence off with one of the saddest things I've ever heard. He said, "I just want to do the right thing." And his daughter remained completely silent. And I watched that clip, and I was thinking, if my parents ever said something like that, if somebody where love exists, you would be leaping in saying, "No, we'll take care of you," right? You're not a burden, and we don't want you to do that. We look at assisted suicide today, and what the reality is that it's actually a failure of our society to respond compassionately where we can actually intervene. And now I'll turn it over to questions.